Good afternoon and welcome. Thank you for joining us for today's National Council for Behavioral Health webinar, Supervisor to Manager to Leader. What is the role of your management team? Featuring MTM Services founder, David Lloyd. My name is Joy and I will be the moderator for today's webinar. Before we get started, a couple of housekeeping items. Today's webinar is being recorded and you are currently in listen-only mode. If you're listening on your phone, please enter on your telephone keypad the audio pin from the control panel on the right-hand side of your screen. At any time during the presentation, please submit your questions. Simply type your question into the dialog box to the right-hand side of your screen and send it to the organizer. Depending on the question, I'll either respond directly back to you or save it for Q&A, and during the Q&A, we will answer as many questions as time allows. An audio version of the entire webinar, as well as a PDF of the presentation, will be available on the National Council website, www.thenationalcouncil.org, within 48 hours. You'll also see in the handout section of your control panel the PDF of the slides. If at any point during the webinar you experience technical difficulties, please call Citrix Tech Support at 888-259-8414. And with that, I'll hand the presentation over to David.
Thank you so much, Joy. It's a pleasure to be with everyone and hope everyone's having a good day. As you will see on the head slide, my email address is here on the head slide. Please, if there are questions following the presentation today or any follow-up information needed that I might cite, a form or something, please email me and I'll be glad to send it to you. My background is this is my second career. My first career was 25 years in for-profit multinational corporation. I was a CEO for 13 of those years. Appointed to a mental health center board in North Carolina because the mental health center wasn't able to pay its payroll in the 1990-91 era because of fee-for-service conversion. I became a board member, and for 2 years I served on that board, and then I retired from my first career. And I applied for a deputy director's job at that center and began to look at accountable care. How could we change what we do? How could we modify and transform our organizations? Out of that came a white paper, and I was asked to start consulting, and the National Council asked me to join them in 1997. My first book, How to Maximize Service Capacity, was published that year. The second one still is in print. The first one is not. How to Deliver Accountable Care. It's basically a textbook on change and management and accountable care within centers. My third book is Leadership Skills to Support High-Functioning Teams. And what I'm going to focus on today is really from that manuscript or that curriculum, if you will, of that book. And then I co-authored Operationalizing Healthcare Reform with other MTM team members. We've had the privilege of working with over 800 community behavioral health clinics since 1993. Basically, we're spending a lot of time right now on how to operationalize value-based accountable care, measurement-based, value-based contracting. Several of you, and in fact, Joy sent out the notice of the meeting and asked if you had questions you would like to submit, because this is really kind of an Ask the Expert model. 6 questions were submitted by last Friday, and Joy has sent those to me. So what I've done is taken the 6 questions from attendees that were submitted in advance, and I've integrated them into my curriculum for today. The obvious point is to try to leave time at the end of the day for you to ask additional questions. But I wanted to start with a question that was submitted by an attendee, which is, as you can see on your screen, what are some of the strategies to be effective in a toxic environment where the leaders are not Peter Singh's learning organization oriented? And Peter Singh is an MIT Sloan School of Management faculty. His focus is on systems change, but it's a horizontal. His whole concept is to deal with change as a family, different family members. And so he's looking across the systems horizontally. And so what I'm going to do, since the model that we actually recommend, and I've recommended in my leadership book, is a horizontal model, then this question I'm going to actually answer as an overarching theme for the whole webinar today, because I think it's a very valid one. Because the challenge we're seeing is what we call silo. We're looking at vertical. This silo, I was just working with a team, and they had 3 different committees in 3 different silos working on the same outcome process. So the question is, why don't we just have one? Why don't we have one committee that's horizontal across the silos, the vertical silos, which would be more of a Peter Singh model. The challenges we're seeing around the requirement to transform ourselves and to change our community centers is really, number one, is accommodating reduced shared risk funding. And shared risk funding would be case rates, bundle rates, global payments, all of those things that look at us being at risk with the payer around outcomes achieved and cost of the services provided. The second one, though, and this ties directly to the first question on the previous slide, is we tend to operate as a vertical silo-based, loosely held federation of private practices. And I just want to unpack that a minute. What I mean by that is that what one particular clinic, program, or location is doing doesn't necessarily meet and match what we're doing at another clinic, location, or program. It could be adult versus child. It could be mental health versus SUD. Whatever the differences are, we tend to operate very vertically, and therefore I call it a loosely held federation of private practices instead of a horizontal focused systems learning specialty group practice model. Back to Peter Singh, his concept is we have to look at horizontal, we have to look at system instead of one silo changing. And a lot of times as we implement same-day access and just-in-time medical scheduling at centers across the nation, you know, some clinics will say, well, one silo will say, yeah, we'll do it, but the other silos will say, oh, no, we can't do that. So in effect, we don't have a group practice, we have multitudes or numbers of private practices. Timely access to treatment, the third one, is a major challenge for us nationally, and we've been working on that for years now on same-day access just in time. Number four is clinically trained managers tend to have a therapeutic-like relationship with their staff. And this is not said critically, but it's basically said, and you're going to see this in one of the questions about consensus. We want everyone to be okay. We want everybody to be all right with all the changes. So we're trying to get everyone okay. And so we're really kind of in a therapeutic-like relationship, which typically results in low accountability regarding staff's performance, behaviors, and attitudes. And so we see performance, or we see behaviors or attitudes that really do, and I'll talk more about them, that really do hamper us from actually changing. Number five, the ability to measure if clients are getting better. We do have HEDIS measures, and we look at quality process measures, but are the clients actually getting better as a result of the service we're providing? Measurement-based care, Joint Commission's new standards for behavioral health indicate that you must have a standardized tool and you must use it to inform the goals, objectives, services that the client needs. So it's not just collecting outcomes, it's actually using it. And then six, the lack of ability to present an objective business case. How do we go out to accountable care organizations, and what do we say? What are our unique factors? Why would you want to contract with our service delivery system instead of build your own capacity? Those are the typical ones. I'm going to highlight number 2 and 4 today because I think those two do really impact sometimes very negatively on our ability to change our organizations. I was asked in 2011, I was asked to serve on a national panel in Washington, D.C. on the future of behavioral health post Affordable Care Act in 10. And the facilitator of the panel said basically, what do you see as the biggest challenge in the next 3 to 5 years for behavioral health? And my quote there in the first bullet was exactly my answer. I said, I think it's the willingness for behavioral health leaders to continually step across the threshold of risk to make bold and creative decisions about service delivery processes and methods. It takes a manager or leader, and I'll further define that, to really make some bold decisions. I mean, going to same-day access after scheduling people out 6 to 7 weeks is a bold and risk-based decision. So it takes a manager to do that and a leader to do that. But also, the second issue that I think is a challenge is we need to make timely, continuous quality improvement-based tough decisions, not perfection decisions, but CQI-based, and I'll talk about that in an era of transformational change. And we need to stick with those decisions in the face of challenge. So many times I call it leadership blinking, but when staff get anxious or emotional, we tend to back off and negotiate, and I'll give you more of that, which really does hamper our ability to actually implement change. And what tools are needed? We need data. It's that simple. We need data. How many people are waiting? When I was working with a team on same-day access, and basically the question kept coming, why do we have to do this? And I said, well, right now you have 164 people waiting up to 9 weeks for a diagnostic assessment. That's why. In other words, data gets past the emotion of this is Sally created this process and Sally will be upset. We tend to personalize it into Bill or Sue's process. or this clinic's process, as opposed to how many people are waiting, how long have they been waiting. Those are data points. Now, what I see, and I do a lot of leadership skills training nationally, in fact, just did 2 days last week, is that basically we see managers, supervisors fitting into one of 3 roles. And this is critically important to your ability to change. Number one, supervisor. It's a reactive, retrospective problem solver. Therefore, he or she processes crisis and also reprocesses crisis, meaning it's almost like we talk about, I ask questions all the time. How many do you know, don't name the staff, but do you know the names of your staff who constantly are turning in documentation late? Everybody says yes. Question, how long have you known those names? And as one person said to me recently, 21 years. Well, if you're continuing to process a performance issue 21 years or 2 years or 6 years, the question becomes, isn't that long enough? And you're going to have to step across a threshold of risk and, number 2, manage the issue and manage it with data. And so I'm looking at how many progress notes are we out, how many treatment plans haven't been signed. I'm looking at data because now I have to actually do something. Therefore, she or he manages complexities. And a manager is the minimum we need today. We are very much more complex in the changes that we're being required from an external source and sources. So we need managers. We need them to be able to be aware using data. We don't need them to be reprocessing crisis. And talking about it one more time, that's kind of that number 1 model, which means we discuss things a lot. We just never implement anything because implementing would be risky. And then we need a leader, coach, mentor. That's where we need to be today. He or she manages and sustains change. A leader, mentor, coach is someone who can see the horizon. Where are we going as a center? Where are we going in terms of collaboration? I've got to be able to see that. But a supervisor is in the weeds of the process and the crisis daily, and they can't see the horizon, therefore. A manager works themselves out of the weeds with data, number 2, and 3, a leader actually delegates so that they can have time to be a leader and coach and mentor. The second question that was submitted, is there a way to assess who among my staff is more likely to be adverse to change? That's a great question. And what I would say my number 1 response, I'm going to give you a couple, but my number 1 response is I look for galvanized managers and staff members that must be identified, meaning galvanized means this. If you mention something, since I've said it, I'm going to say same-day access. If you know before the manager or the staff open their mouth what they're going to say, and it's usually negative about why we can't do same-day access, I call that galvanized, meaning it's very hard for them. They're basically defending their position. They're defending. Sometimes we have longevity produces galvanized managers, meaning I've been here a long time. We tried this 10 years ago. It won't work. So when I've got galvanized managers and staff, I do not select them for change initiative work teams or process. Because if they're not able to look beyond themselves and beyond what they're doing right now, I call it moving about 2 feet back from their day-to-day roles. Can they help envision? Remember, envisioning is the leader's job. Envisioning and using data is the manager's job. If they're just saying simply it won't work and it won't work and it won't work, I call that galvanized. And that's a tough way to change an agency. So that's my first response. And so can you, without saying their names out loud, identify who on your management team or on your supervisory team or within your staff are galvanized about any issue? And the only way you'll know that is they've told you over and over and over their position, and they feel very, very strongly that their position is right. To take those galvanized managers and staff and try to put them into a change initiative is tough because it takes so much time and it consumes so much energy to try to do that. My second response is look at the spectrum of disruptive manager or staff behaviors that create tremendous challenges to change. Number 1, aggressive behaviors. We're pretty good at identifying that, inappropriate anger threats, yelling publicly, intimidating fellow staff. We're very good about identifying that within our staff or managers. But where we tend to really get bogged down to who should we choose for this change and which staff may not be the right ones to select for this change initiative is passive aggressive behavior number 2. Hostile notes or emails, derogatory comments, always talking about something, always complaining, always blaming. It's not my fault, it's the director. I tried, but this is not going to work for my team, my staff, my team, my clients. Always that constant passive aggressive type behavior. If I've got a staff who exhibits that routinely, I will not select them for a change team. I will not select them to be a part, because it takes too much energy to get past their emotion. And then thirdly, the passive behaviors: chronically late to meetings, chronically late to submit deadlines, failure to return calls, avoiding meetings, they're not really participating. They're sitting in the meeting and doodling. They're just not really involved. They're ill prepared, not prepared, chronic excuses. Well, I tried to get to it. I just ran out of time. If I have people who fall in 2 and 3, back to the question was, is there a way to assess among my staff which staff is more likely to be adverse to change? I'm going to look at galvanization, and I'm going to look at my behaviors, particularly passive, aggressive, and passive. And if I can say that person or these persons fall into that, I will not include them in the change, because it takes too much energy to pull them along. It's like walking through a change with a big old steel ball kind of chained to your ankle. Third question. What is the best way to handle staff that aren't open to change without negatively impacting the morale of the rest of the staff? And this is critical, because there's only one way I know, and that's this particular chart right here. I spend a lot of time on this in my book, but the key thing is the way that I can change the staff and change the process and not affect morale negatively is if I have a leader who's at number 6. This, back in 1993, when I joined the Behavioral Health Center, I was not aware of the grieving that we would have to go through to change a form that we'd used for 22 years. I mean, in for-profit world, we changed so frequently, there was not a lot of grieving. But what I realized after trying to make changes, I went back to Kubler-Ross in my clinical studies in the 70s, and I said, okay, there's a process here of grieving, and this is what I developed, obviously giving credit to Kubler-Ross. But basically, the first thing that we do when we start talking about change is denial. Why do we have to do this? Well, we have 164 people waiting 9 weeks. That gets past denial. Now, here's where we usually get stuck: negotiation. Basically, well, it won't work for my team. I bet you've never heard that. My program is a little bit different. I bet you've never heard that. My staff are very different. We serve child and adolescents, and they are very different than adults. Or we provide IDD services, which are very different than substance use disorder services. We tend to, in our loosely held Federation of Private Practices, negotiate our way out of the change because we're different. We just are different. I understood this, but what I also understand is if I've got a team of staff, a unit or a program being managed by a supervisor, remember, supervisor, manager, leader, then basically they will be in the negotiating model, and they tend to try to push their staff to change. They're not sold on the change, and so they're basically saying, the director said we had to do it, but basically they're saying, I apologize to you for, asking you to do this, but I didn't want you to do this. It was the director, or it was the board, or it was the senior executive leaders. I'm putting the blame on someone else because I want my staff to be happy. You see, here's the point. To be a supervisor, the key role of supervisor is that I want to be liked by my staff. Uncle Al and Aunt Sal, the staff's pal. As a manager, my key role is I want to be respected by the staff. Whether they like me or not is not my primary goal. My primary goal is to be respected for the information I can bring, for the effort I will give, and for the help and change process and eliminating barriers that I can provide. Supervisors tend to stay up there at I want them to like me, I don't want my staff upset, those kinds of things. So when we get to negotiation, and what we call it is a 1, 2, 3 dance, supervisors will say, no, we got to do it. We have 164 people waiting. Well, they said we all had to do it, but I know we're different. And as soon as my staff realize that we have to do it, they get anxious, then we go back to the negotiation. Well, let's delay this. Let's delay this a month, and let's talk about it some more. And then we'll try it again in March. And then people get anxious. Oh, my gosh, so let's go back to negotiation. It's called the 1, 2, 3 dance. What I'm suggesting is these first 4 steps in acceptance process are emotional steps. And when you have an organization that has primarily supervisors managing staff, then you will have your staff in a very emotional state, which destroys morale. Because there is no conclusion, there is no where are we going. It's just people are anxious, or I'm just going to leave. If I knew I had to do this, I would leave. see, I've got to get all my staff to accepting the need to change, not accepting that I like it or not like it, just accepting the need to change. I understand I have to do it. I may not like it, but I have to do it. Where you have to have your leadership and your managers is they have to be at number 6. They have to be excited about taking advantage of this opportunity. A supervisor in electronic record implementation will say, oh my gosh, look what IT is doing to us again. That's number 2. And I don't think this will work for our team. I think we need some workarounds. A leader and who's at number 6 will say, my gosh, look at what opportunity we have for you to learn computer skills, and we can help you with those skills. We'll coach you with those. But this is a tremendous opportunity for you in healthcare to learn a new system of electronic record keeping. You see, the leader pulls staff through 1, 2, 3, 4, 5, because the first 4 steps of this acceptance are emotional steps. Number 5 is the first neutral step emotionally, and number 6 is a positive emotion. Look what we can do. This is exciting. So if I've got staff that I'm concerned about their morale, I need my managers to step up and pull and get excited about what we're doing. They cannot be up here at number 2 negotiating, nor can they be anxious. Here's the key. Wherever your managers are or supervisors are in this 1 to 6 acceptance curve or process, their staff cannot get beyond them. So if your manager supervisor is negotiating, I'm still trying to get the senior management team to back off this standard, or if they're anxious about this change, or they're going to be leaving because they don't think it's fair, their staff cannot get beyond them to number 6. So if I look at the major issue, I'm looking at leadership to respond to this question. I've got to have my leaders to move people along this continuum of acceptance so that I don't negatively affect morale, because as long as I keep them up here, denial, negotiation, anxiety, I'm going to leave, or back to negotiation, there's going to be morale issues because everybody's upset. Now, the next 2 questions I put together because I think it's really important, because they're basically saying the same thing. My team is used to a consensus decision-making process. How can I effectively lay the groundwork for changing this was one question. And secondly, I'm currently in middle management. The leadership at my organization are big fans on involving everyone in most decisions. I call that the herd model. We're going to have a committee of the whole. We're going to have 57 people here to talk about how we're going to change. This causes delays in important processes being implemented. Thoughts on if there is something I can do to influence leadership. And the first one is here. If I want to influence leadership, this is actually a change management decision-making assessment that MTM uses. I'll be glad to send it to you. It's basically a PDF or a Word document. But basically sit down, and if you're middle management, start answering these kinds of questions. You know, are you able to change quickly? Are you able to fully implement number 3, number 4? Or number 5, are you able to see that staff rarely retreat to the way things were before? And if it's true, say true. If it's false, then say what's more accurate. Do you use rapid cycle number 2? Do you have a strategic annual plan? And if so, yes. If so, what percentage of your goals did you complete for the last 2 fiscal years, whatever time frame you want? But this allows you to present data to senior managers to say, from my perspective, this is where we are in our decision-making process, which is not working for the organization. See, this is about the organization surviving. And so I think that's important. Now, back to the consensus model and the consensus questions, the 2 of them. What I have found, consensus processing equals staff and organizational level disempowerment. Consensus building focuses a good clinical skill that social workers are taught. We're taught that even today in MSW curriculums. We need to build consensus, and it's great when using it in working with our clients and their families. It is not a great tool in working with change management within a behavioral health center. And that's what I mean by a therapeutic-like relationship. We tend to take our therapeutic skills and knowledge and try to convert it to management. And that is not necessarily working for us. What I'm suggesting, secondly, the consensus model decision-making in our community behavioral health clinics actually produces disempowerment for the project team members and the organization due to the elongated planning discussion phase. Plan, do, study, act, PDSA is rapid cycle. What we tend to do at behavioral health centers is we plan. Let's talk and talk. Oh, you're upset with this. Let's get back together. Let's talk about another 2 or 3 weeks, another 2 or 3 months, because everyone's not okay with it. And what we never do is the second step, which is do something. We can't study the outcome until we actually do something, which basically seldom produces this process, consensus process, seldom produces timely implementation, which is the point of the 2 questions. Consensus decision-making creates staff change fatigue due to the staff feeling like the organization will never actually change. I can't tell you the number of staff that say to me when we go in for project management and change management, we constantly are talking about change. We're constantly talking about the need to change. And when I say, how many are tired of talking about the need to change, a lot of hands go up in the room. Then I ask a separate question. Ask your staff this question. How many people are tired of change? Not talking about it, actually doing it. And I may have 1 or 2 hands go up, and it usually is 1 or 2 departments. So the question in this consensus model that I always want to ask, and we have meeting evaluation forms, be glad to share them with you, is what did I accomplish? If I'm a member of this team, what did I accomplish in the past 2-hour meeting? And if the answer is the only thing I accomplished is to negotiate when we're going to meet again, then that's probably too much consensus processing. You see, what I see where organizations are changing is they're changing at C-level. That's where objective information, where staff, managers, and leaders need to reside to support objective decision-making, or compliance, or revenue generation, or whatever. And this is where the solution design and implementation of change will occur. It's not 10,000 feet. Consensus models puts us typically at 10 to 20,000 feet above sea level, where we primarily talk about philosophical concepts. And here's how I feel, my personal opinion. I think it's much better. What is your no-show rate? Oh, it's much better than it used to be. What did it used to be? Oh, much worse than it is now. With those kinds of data, we can't make any decision. And all I'm saying is we tend to stay at the 10 to 20,000 feet because it is not risky up there. And what we do in consensus is we basically get into the what if. So if you want to implement same day, well, what if? And so we have everybody questioning philosophically what same day will look like. We just have never done it literally and physically. So we can't really measure it. As one clinical director said to me recently, I'm not going to approve same day access until you tell me what happens on Monday morning when 8 clients arrive and one's having a grand mal seizure. I said, how many grand mal seizures have you had in your caseload in the last 2 years? The answer was 0. But you see, we got to prepare for the worst. What if and consensus processing allows us to look at outliers, not look at what the majority of our clients need. We always focus on the outliers. So in effect, what we do in consensus models is we do sequential change, number 1. We don't change but one thing at a time. Let's do this, then we'll do this, and we'll do this, which creates change fatigue. Secondly, we do that in the consensus model with perfection. We can't move forward until everyone here is happy with this. That's perfection. And you rarely do not get there in a timely way. What we've got to focus on is transformational change. That's a continuous quality improvement, CQI, and PDSA, around multiple goals at one time. And we're going to use, number 5, we're going to actually implement the pilot on same day next Monday, and we're going to learn in the first hour what we need to change, because we got about 70% there, but we're not going to make it perfect if we talk about it for 6 months, the what ifs and the what ifs. We've got to rely on a manager stepping across a threshold of risk and saying, let's implement this and let's learn from our process at sea level. What is happening right now? So in effect, what I've created here on the left is the committee of the whole model. Committee of the whole is what I call a consensus model. We have to have a lot of people at the table. We've got to have everybody there because everybody needs to have input. Social work model. That's basically a good clinical process. It is not in management of change. We basically, you can see the qualities, sequential, one at a time. We do QI. We have to make sure it's perfect. What if? And so we can't implement until we go through the whole what ifs. Galvanized team members, they tend to sit in there and just say, it won't work. And we basically, the collective authority does not support the individual responsibility. So let's say we're going to ask Joy when we end this meeting to go out and implement this, but the authority is not with Joy, it's with the consensus group, the committee of the whole. as opposed to a delegated authority model where we look at transformational change, multiple change goals at one time, continuous quality improvement. And we look at a 70% decision making which addresses the galvanized members. I can't overcome galvanized members if they're on the committee unless I approve everything by process of decision making that's called 70%. See, when Joy goes out in this model, she's given the authority to take on the level of individual responsibility we've asked. So in effect, this is a decision-making process that I would strongly recommend you look at. We're going to try, number one, to come to consensus, but in a reasonable period of time, if I'm hearing the same thing from the same person for the third time on my team, then that's avocation. That's not processing to solution. So I'm going to ask for a preliminary straw vote. How many in favor of Joy's recommendation for solution? How many opposed? And then in a reasonable period of time, next 2 or 3 minutes, let's try to get the consensus. If not, Joy, would you make your recommendation in the form of a motion? Is there a second to Joy's motion? All those in favor signify by aye. All those opposed, nay. And 70% of the people in that room decide where we're going. And if you're not comfortable with implementing it fully, then the 70% vote would be for a pilot program. So let's pilot it, Joy. Give us 2 weeks outcome on that, and we'll come back and look at it center-wide. But this decision-making process, we will not accept a project and manage projects with individual centers, statewide or regional, unless they agree to this decision process. We have meeting guidelines that further elaborate these, but I would really encourage you that you need a decision process that eliminates your galvanized members and this consensus need that everybody's okay. It's just not working for implementation. What level of staff and how many staff would you recommend involving in decision making? And my answer is 4 to 5. What I'm going to do is not have a committee of the whole up at the top. I'm not going to have 37 people trying to make a decision. I'm going to actually, number 6, select a project manager, and I'm going to delegate. The CEO, executive director, delegates written authority to that person to take on the responsibility that you've identified, let's say implementing same-day access. And that project manager, him or her, selects 4 or 5 project team members that they choose, and this goes back to Peter Singh, they choose across horizontally the programs, and you involve project team members who actually have an involvement in the current processes and have a baseline of current operational clinical data, process data that will help you solve, because you can't solve anything until you know where you are now, but it reaches across the silos. So that 4 to 5 people, but that's all I need. I need a project manager, 4 to 5, and they make decisions. I don't need 37 people being okay with it. Wow. I hope this has been helpful, and I hope we've responded to the questions pre-submitted, but Joy, I'm going to send it back to see if there are other questions or if we have time. I know we're right at time now.
No, thank you, David. This was extremely helpful, and I've gotten lots of good feedback on this is helpful and where are the slides. We do have time for one question, and I will go ahead and read this to you. I'm an administrative director in the midst of a leadership change. The new executive director has made a decision with the board that I feel was the wrong decision. I've accepted that I've lost the battle, but now I have to figure out how to get my staff to accept it. How do I do that without just saying, well, that's just how it is?
Okay. Then I'm going to come right back up to this slide. Again, apologize for the movement, but I've got to come up to this slide. I think there, as an administrator in a facility, what I've got to do is get out of the role of being a negotiator. I can't negotiate for the new CEO or for the board. The decisions that were made were made. My job is to accept that, at least get to 5. I have to accept that that is the decision, because it's not my decision to make. It was a decision someone else made based on the chain of command and the board and the new CEO. So my job is to get to acceptance. My staff will pick up very quickly when I'm still up there negotiating, or I'm anxious, or I'm angry and blaming because I don't like it, or I'm thinking about leaving. I need to get to acceptance, and as quick as I can, number 5. But secondarily, as quick as I can get excited about it and try to really talk with the CEO and with the board and get all the input you can about why this could be very positive for us. This could be a very good opportunity for us. Then my job is to start at 5 and get to 6 as quick as I can. If not, your staff will never accept it. If I'm still up there, and I would say print this slide out, team, and put it on your desk, and when changes are occurring and you're asked to manage them, you need to define where you are in 1 to 6, because wherever you are, your staff will be right there with you.
Great, thank you, David. Well, that is all the time we have today, but thank you all for joining us for this webinar. Again, the recording and PDF of the slides will be available on the National Council's website within 48 hours. We thank you all for attending, and do feel free to take the survey at the end and then get in touch with myself or David if you have any questions or want additional information. Thanks so much, and everyone have a great afternoon.
Thank you, everyone. I hope it was helpful.